Hi, everyone. My name is Viranshi Vira. I am currently a senior at Geffen Academy at UCLA, and I'm going to be talking to you today about a study I did examining racial disparities in maternal mortality rates, specifically the disparity between Black and white patients. Hold on, it's not. Okay, my slide isn't changing. Just give me 1 second. There we go. Okay. So I wanted to start by defining maternal mortality. So the CDC defines maternal mortality as the death of a woman during pregnancy, at delivery, or soon after delivery. And these are usually caused by complications pre, during, or post-delivery. The complications that contributed the most to the Black-white disparity are preeclampsia or eclampsia, postpartum cardiomyopathy, and obstetric embolism. The racial disparity in maternal death is not something new that has been happening only recently. It has existed for almost 100 years. States first reported maternal deaths in 1933, where the disparity between Black and white patients was first revealed. And in 1933, Black women's mortality rate was 1.8 times that of white women, where Black women experienced 1,000 deaths per 100,000 births versus 564 deaths per 100,000. This number has only increased, and in 2018, the mortality rate was 2.5 times that of white women. One thing to note is that most of these deaths are preventable, which increases the importance of studying the factors that contribute to the racial disparity in the deaths. This is one of the reasons why I chose to study this topic. I read a lot of articles about how Black women experience maternal mortality at a much higher rate than white women, so I wanted to know why that was happening and how to change that. So to conduct this study, I did a literature review using an AI called Illicit, where if you type in keywords into the search bar, it will bring up papers and studies that are related to what you're interested in. So I typed in the question, why do Black women have a higher maternal mortality rate than white women? And this led me to study 4 papers, and I made sure that all these papers were published within the last 10 years and had a high ranking on the Scimago Journal rank. For defining key terms, I used pretty reputable sources. For example, for the information that I learned about postpartum cardiomyopathy, which is a complication in the heart, I used information from the American Heart Association. This is a table that compares maternal mortality rates in women across races. As you can see here, the confirmed rate of maternal mortality for non-Hispanic Black women is 3.5 times that of non-Hispanic white women. The rate of late maternal mortality rates for non-Hispanic Black women was 3.52 times that of non-Hispanic white women, and combining the two shows an overall disparity of 3.55. I divided my key findings into 2 categories: clinical aspects that contribute to the disparity, which are pregnancy complications that can result in death, and the social aspects, such as socioeconomic disadvantage and racism. So these are the complications that contribute the most to the racial disparity in maternal mortality rates, and these are some of the most commonly experienced complications just in pregnancy generally. And the first one that I studied is preeclampsia or eclampsia, which occurs when high blood pressure in the mother reduces blood supply to the fetus. Eclampsia occurs when a woman with preeclampsia begins to have seizures and is at high risk of going into a coma. The next complication I studied was postpartum cardiomyopathy, which is heart failure that occurs towards the end of pregnancy or within a few months of giving birth. Obstetric embolism occurs when amniotic fluid enters the bloodstream right before, during, or after giving birth. And obstetric hemorrhage, which is the last complication that I looked at, which is bleeding during pregnancy, delivery, and or the postpartum period, and can lead to severe blood loss and death. Another thing I found was that Black women have higher rates of going into C-section deliveries as opposed to white women, and going into surgery does increase the risk of complication and death. So I know you can't see the numbers very well here, but this graph highlights the rates per 100,000 live births at which non-Hispanic white, non-Hispanic Black, and Hispanic women die from the previously mentioned complications. So here, maternal deaths is defined as from pregnancy up to 42 days postpartum. The very last column here shows how much each complication contributes to the disparity in percent. So at 22.1%, preeclampsia and eclampsia contribute the most. Black women die from that complication at a rate of 3.93 per 100,000, as opposed to white women who die from that complication at a rate of 0.78. Postpartum cardiomyopathy had a 19.1% contribution to the disparity, making it the second largest contributor. And Black women died from that at a rate of 3.42, as opposed to white women who had a mortality rate of 0.7. You can observe similar patterns in the rates of deaths caused by these other complications listed here. This table is similar to the previous one in that it shows the rate at which women die from different races die from certain complications. The difference is that it shows data of deaths from the late maternal period instead of the maternal period, which in this case is 43 days up to a year postpartum. And regardless, the leading causes of maternal death show us similar results in that Black women have a higher mortality rate from these complications than white women. The first social aspect I studied were the socioeconomic factors that can affect the disparity. Due to a history of racism, Black women are more socioeconomically disadvantaged than white women and are provided with less opportunity to kind of get out of those situations, which leads to increased stress levels. These stress levels can lead to a variety of health issues, especially in the heart. This is important to consider since postpartum cardiomyopathy is the second largest contributor to the disparity, and the complications previously mentioned can all escalate into much larger issues if the person experiencing the complication is under a lot of stress and has less access to care. Lower socioeconomic status also makes it more difficult to obtain access to proper healthcare, making treatment for these worsening complications less frequent. I also found that 2/3 of Black women have Medicaid, while the majority of white women use private insurance. This would prompt me to draw a connection between private insurance being more beneficial towards maternal health, but I currently do not have enough information to make a claim on that. I also studied how implicit bias and racism can affect the disparity. I studied papers that analyzed the social interactions that medical providers have with their Black patients and found that medical providers are more hostile in their interactions with Black patients as opposed to their white patients, and often do not listen to their Black patients' concerns and dismiss their pain. There have been experiences in the past of Black women being studied without their consent, such as in the J. Marion Sims experiments. J. Marion Sims was a 19th century doctor whose experiments contributed a lot to the field of OBGYN, but his most famous study was one he did by operating on enslaved Black women without their consent and without using anesthesia. This built two narratives about Black women in the field of healthcare, the first being that it is okay to do things to Black women in a medical setting without their consent, and the second being that Black women feel less pain. These stereotypes have been used in practice through generations of medicine, and while medical providers may be more aware of those today, the implicit biases are still present in their practice due to the training they received. These interactions cause more discomfort to the patient, and it is much more likely that a patient will be put in a life-threatening situation when these needs are ignored. So my study also prompted some solutions from both the papers I read and some things I came up with. So the first thing I found was that more engaging racism and bias training for those entering the medical field is needed. And while these trainings do exist and are required in many places, there needs to be a greater effort to ensure that those practices are being followed in real life settings and that participants are retaining the information. Right now, they're simply online modules that people don't really pay much attention to. So having more engaging training as well as supervisors doing routine checks to make sure that those practices are being implemented clinically will make a big difference in the quality of care Black women receive. The second solution I found was that an increased awareness of the complications that contribute to maternal mortality and how to prevent them from escalating into life-threatening situation is needed. Some experts have recommended a hypertension safety bundle, with hypertension being high blood pressure, and that would provide clinicians with information and suggest treatments for pregnant women who have hypertension. Similarly, an obstetric embolism safety bundle was also suggested. And finally, an earlier detection of these diseases will allow time for treatment before they progress into larger issues. So I would like to explore in the future the connection between private insurance and Medicaid and how that contributes to, and if that contributes to lower rates of maternal death. Right now, with the information I have, I can raise the question, does having private insurance mean better insurance and therefore access to better care? And is that a factor that contributes to the lower maternal mortality rate in white women? But I don't have information on that to make a definitive claim, but it was something I would like to study in greater detail. The second thing that I was wondering a little bit about is the diversity within Black populations, as most of the studies that I used made a distinction between non-Hispanic Black women and non-Hispanic white women and had Hispanic women as a separate racial category. So why were the racial groups categorized this way? And that is something I would like to look into as well. This concludes my presentation. I wanted to take a moment to thank my mentor, Dr. Shea, whose guidance and support helped make this project a success and made me more interested in this field. And I would also like to thank Dr. Ashworth, who's my teacher at school, and she taught me the fundamentals of research and how to do research, and she continues to encourage me in whatever I'm passionate about. These are the sources I used, and thank you so much for listening to my presentation. Please ask me any questions you may have.
Thank you so much. We have 2 questions so far. So kudos for you for doing such important and challenging research. What advice do you have for other young scholars who are tackling topics that are emotionally heavy? How did you manage your own emotional response and mental health while pursuing this meaningful project?
Yeah, that's a great question. So there were definitely times where it was difficult to read some of the reading I did, but I also focused a lot on more analytical papers that are very data heavy, although it still was kind of heartbreaking. And my advice would just be to kind of, you know, it's okay to take a break sometimes. Like if you are doing this kind of research and, find that it is challenging, pause for a minute, drink water, take a walk, and then when you are in a fresher or more calm headspace, you can get back to it.
Great. Yeah, that's great advice. I'm sure that relates to many of our students' projects. Okay. Is there any research on how racial or socioeconomic disparities affect a mother's decision to seek regular checkups and/or symptom treatment throughout and immediately after pregnancy?
Yeah, so one of the things that I found, and I guess I should have been clearer about it in the presentation, was that because Black women are generally of lower socioeconomic status, the access to care is less accessible to them, and that includes how often they go for checkups, because it might be that the nearest hospital is too far for them, or they have to work long hours and don't have time to go, or they can't afford to go to the hospital that frequently, and that definitely affects how much their doctor knows about their pregnancy and how they're treated in the delivery room and throughout their pregnancy.
Got it. Yeah. Okay, one more. You stated that most of these causes of death are preventable. How do you know what medical care is needed to reduce maternal mortality?
So they are preventable in that a lot of these medical complications are treatable in a medical setting. But what often happens is that for Black women, they rapidly escalate into being life-threatening situations before medical providers can properly gauge what's happening. And a lot of that has to do with Black women not being able to go get checked by their obstetrician as frequently, and also and it also has to do with what I found about how even if a Black woman can tell that something is wrong with their body, a clinician will most likely ignore that concern unless they themselves see something is wrong.
Got it. And then my personal question, same as Caleb's, what was the most interesting or surprising thing that you learned?
I knew about like a little bit about the topic before I studied it, but what I was surprised about was that I found that the disparity between maternal mortality between Black or white patients was actually something that's been going on since 1933. I thought it was like a newer thing, but after doing more research on the history of medical practices for Black patients, it actually made a lot more sense.